Education is a key pillar of guideline-recommended care for osteoarthritis or OA. This systematic review describes the impact of OA education on knowledge, beliefs, and behavior, and how and why these changes do or do not occur. We searched 5 databases and included 98 studies, 85 in the quantitative analysis and 16 in the qualitative analysis. We then used a novel 5-stage mixed methods data synthesis process to capture the breadth and depth of this very diverse dataset. This included narratively synthesizing the quantitative data and qualitizing it, which means we converted the quantitative data to narrative form. We also inductively analyzed the qualitative data and organized the themes into maps using a process called rhizoanalysis. Finally, we collated the qualitative and quantitative themes to identify 3 meta-themes and compared them with the overarching rhizoanalysis map for added rigor. Through these analyses, we found trends to indicate that education can improve and reinforce knowledge about OA and its management in the immediate and short terms, that is, up to 6 months from the time of intervention. There were no consistent trends in beliefs and behavior change, with evidence of various intrinsic and extrinsic factors complicating this process. How and why these changes in knowledge, beliefs, and behavior occurred or didn't occur were related to 3 important factors. The first is engagement. People tended to engage better with education that was appropriate to their individual needs and came from what they considered to be a trusted source. Long-term, ongoing education and support appeared to play a role in maintaining engagement, maintaining changes, and allowing opportunities for further change in knowledge, beliefs, and behavior. The second is embodiment, the physical process of learning and putting knowledge into action. We found that when theoretical education is accompanied by additional support that targets specific beliefs or behaviors, for example, coping with pain or support to do exercise, it could enable positive change. Importantly, it appeared that individuals also learn from their own bodily experiences of osteoarthritis and through experiencing change in symptoms after participating in management strategies. Empowerment refers to the level of agency that the education process generates to make and maintain change. This could be influenced by whether education addresses individual needs and preferences, for example, being relevant to one's culture and literacy, or factoring in their time and socioeconomic constraints. We also found that what health professionals know, believe, and do could either empower or negatively influence changes in patients' knowledge, beliefs, and behavior. Based on these findings, we encourage clinicians and researchers to rethink the traditional unidimensional approach to OA education and its outcomes, and recognize how engagement, embodiment, and empowerment can be applied to the provision and evaluation of OA education.